Hi everyone, thank you for joining us for this evening for the ninth week of the Rugby Research and Injury Prevention Group's 2025 Summer Lecture Series. We're going to start tonight with our featured speaker, Dr. Mahesh Bagwe. Dr. Bagwe is an orthopedic surgeon and a lower extremity specialist at Ortho, Missouri. Dr. Bagwe, could you share your screen with us, please?
Was that on your left? So lateral ankle stabilization, basically in sports. So specifically, I'm going to talk about the way we do the repairs now, which has kind of changed from the way we did it a few years ago. So if this gets too technical, I might not get into the technical parts of how the surgeries are done, just more like an overview. So I'm in St. Louis, Missouri. I've been doing surgery for 21 years in practice. First 15 years, I did a lot of trauma of everything: elbows, wrists, shoulders, hips, knees, ankles. And then the last 6 years, more focusing just on knees and ankles. I did St. Louis Cardinals team doctor and lower extremity consultant from 2019 to 22. And then I treat young athletes and adults for ankle injuries and a lot of knees as well. So real common, 16 to 40% of all sports injuries or ankle injuries. 14% of all ER visits are ankle injuries. NFL Combine participants, basically half of them have had at some point an ankle injury, which then usually means they get an MRI and an evaluation to make sure that there's not something still going on. Usually this involves the outer side of the ankle, the lateral ankle ligaments, and 60 to 85%. And the CFL is basically another ligament also on the lateral side, which is right next to the ATFL, but that usually is injured at the same time. And then the medial ligaments, about 5 to 15%. And then a portion of people have cartilage injuries, which is what OCD means, osteochondral injury, which means a cartilage injury in the ankle. And then a 67% of syndesmosis, which you guys might know as a high ankle sprain. And then the peroneal tendons, which are on the outer side of the ankle, which stabilize the ankle. When the ankle turns too far and these tendons get overloaded, the tendons can get a tear as well. Syndesmosis injuries are a little bit higher in hockey players because their foot is stabilized. The whole foot rotates around the tibia and spins. And so that causes them to have these high ankle sprains. So people get ankle sprains. And as I tell patients in my office who come in, they usually don't need surgery. The ones that need surgery are the ones that have instability. As far as the ligaments go, if they have a cartilage injury or a tendon injury, that's different. But as far as the sprain part, people have instability when their ankle basically isn't being held in socket very well anymore. And that usually means that one of the ligaments or two of the ligaments are torn and loose enough that when they walk, it lets their ankle start sliding out of socket. Okay, so these symptoms would be recurrent sprains. So people who have a one bad ankle sprain, and then somehow every couple months they have another bad ankle sprain, and they don't even know what's going wrong. Or a lot of times that people just walk on a flat ground, they'll have ankle sprains just walking along, not even doing anything or tripping on anything. Just because the ankle is unstable and the ligaments aren't holding their ankle in socket well. And sometimes it just presents as swelling and pain. People don't know why their ankle keeps swelling up and it's painful. And that's because as they're walking, their ankle, the outside is just bouncing, and that causes the ankle joint to get irritated. So the structures, the ATFL, which stands for anterior talofibular ligament. So anterior means the front, talofibular is between the two bones, the talus and the fibula, and CFL is called calcaneal fibular ligament, CFL. PTFL is posterior talofibular ligament. So basically, the ATFL and the PTFL, one's the front and one's the back side of the talus attachments, and then the calcaneus has an attachment on the outer side as well. Syndesmotic ligaments are the ligaments between the fibula and the tibia that stabilize. When your ankle goes up and down, your fibula rotates in a groove. That's the outer side of your ankle and gives a little bit of rotation. And it also moves a little bit up and down when your ankle moves up and down. Just a little bit of motion, and that stabilizes the ankle. So that's the syndesmotic ligaments holding the fibula. The capsule is the covering of the ankle joint. And then the tendons crossing would be all the tendons around the ankle. In the front is the tibialis anterior. On the sides, there's the peroneal tendons on the outside, the posterior tibial tendon on the inside, and the Achilles in the back. So here's a little diagram so you can see some of the things I'm talking about. The posterior and the anterior talofibular ligaments going from the front and the back of the talus up to the fibula. You can see the Achilles tendon in the back, which I put together, just left fixing one just now. Calcaneal fibular ligaments. And then as that says on the side, the posterior side is injured a lot less. Usually it's the front corner, the front outer corner, which is the ATFL ligaments. Any questions so far, guys? Am I going too fast? Okay. So the ATFL originates a centimeter from the tip of the fibula, okay, and inserts on the lateral neck just beyond the articular surface. I wonder if I have a pointer here. So that's actually what they're marking as number 8. I should have labeled that. Sorry. So right from here. I don't know. Can you see my pointer on the screen? Okay, and that's the side of the talus. Um, and it attaches right next to the cartilage. The cartilage is here, the ligament's going across here. When you sprain your ankle, any of you guys, somebody sprained their ankle before, you're actually tearing that ligament. Usually not the whole thing, usually some portion of it, 2%, 10%, 20%. The people who have a lot of problems, usually it's when they tear 50% or more. And when it heals, it either doesn't grow back because it completely tore the whole thing, or it heals up loose. The two sides never really get tight again. Okay. So risk factors for people having chronic instability. Um, these are a little more detailed medically. So cavo varus means people who have a high arch or their heel points in, and it's just the shape of their feet. Are people who walk on the outside of their foot. They're just kind of prone to rolling their ankles. Okay, so when you see people who have repeated ankle sprains, you basically want to look to see is there something about the alignment of the leg. It's just their natural anatomy that predisposes them. Or do they have an old injury as a kid and they broke their leg and now their ankle's a little bit crooked, the whole leg is a little bit crooked, and it leads them to keep their ankle keep giving out. Tibia vera means it's the same thing. A varus tibia means you're basically bow-legged, and that would put too much. That would make your ankle want to roll to the outside. Perineal tendon injuries. So perineal tendon injuries. Those are the tendons on the outside of the ankle. When you twist your ankle or roll it, those tendons are the ones trying to pull your body back straight. If those tendons aren't working, when your ankle starts to roll, there's no way for your muscles to counteract that and pull your foot back underneath you. So, and on the other hand, when you step in a hole and your whole body twists over your foot, those tendons are trying to pull your body, but there's no way they can do it because your whole body's rolling. So these tendons get injured frequently. And so the typical pattern I see is I'll do a surgery where I'm repairing the perineal tendons on the side of the ankle and repairing the ankle ligaments on the, like, such as the ATFL ligament. And I put the camera in the ankle and I repair broken cartilage. Those set of 3 happen quite a bit. Okay. Ligamentous laxity. So some people, usually it's women, have a lot of ligamentous laxity. What does that mean? They're very flexible. Okay. And that has good things and bad things. Being extra flexible, for sports maybe means you get less sprains. But on the other hand, for things like joints, things can go too far. So, for instance, when they sprain their ankle and their ankle is already looser than most people's, and now they sprain it, it real quick gets to be too loose. So when I have somebody who, a young, especially a young female athlete, let's say 14-year-old, comes in, they have an ankle sprain, one ankle sprain, and they tell me, well, now their ankle buckles all the time. That's a little strange. But then they show me that they can bend their thumb down to their forearm, their elbows are hypermobile. They can pop joints in and out of socket. Well, those are basically young people who have too much flexibility, and the problem with that is it can lead to the ankle being unstable. So that's that ligamentous laxity. And what does that change? It doesn't change a lot treatment wise for me, except that I realize that for those people, it might only take 1 or 2 sprains, and now they have an unstable ankle. Whereas everybody else who has a bad ankle sprain, I try to rehab it first, try things without surgery, put a boot, brace, physical therapy, things like that. I still do those with the people with ligamentous laxity, but in the back of my head, I know they're probably going to need a tightening. Okay, let's keep going. So this is some anatomy. This is the idea what it looks like to sew a torn tendon together. So this is the way I did it when I started doing this 20 years ago. It's called a brostrum. Brostrum means you take the torn ATFL, you go down there and you see it's all stretched apart, and torn, and you basically take suture and you sew the two sides together. It's called a primary repair. And you sew them tight. You basically put the sutures in and you tie knots and you try to pull it tighter than it was to cinch it together. The nice thing is you're doing the exact same plane of the tissues. You're pulling it together. So that's called a restoration of normal anatomy and joint kinematics. You haven't created a new ligament source, a new point of pulling. You're using the original one and you're just tightening it. Okay. The negative to this is you're taking bad tissue that's already been injured multiple times and you're using that as your repair. So they changed it. This is a long time ago. So this is the Brostrom procedure, which is just pulling the initial torn ligament together. And then it's called a modified Brostrom. Modified Brostrom is the Gould modification. You add the CFL, so you go kind of underneath the fibula, and you take a band of extensor retinaculum. The extensor retinaculum is this band of tissue that goes across the top of the ankle. So now this is a modified Brostrom. You've taken this extra band of tissue that goes across the front, and you you make your incision a little bit bigger so you can see it. You pull that up, and then you also grab a little bit behind here. These are the perineal tendons. You can see with my arrow, those are perineals. You grab, this is the calcaneofibula ligament, the one that's going back to the calcaneus. You grab some of that. You grab your ATFL and your extensor retinaculum. Now you have a modified brostrum. So this is the way I learned how to do it. But once again, you're still pulling on that previously injured ATFL. Okay, it's a strong repair, but even I would notice that at times people would start having sprains 4, 5, 6 years later, and the ankle's loose again. And if it comes loose again after this repair, we basically have to do more drastic things like getting a piece of tendon from a cadaver, a dead person, and taking a piece of tendon, putting in anchors, and trying to rebuild a new one by creating a new ligament by putting bone anchors in. And the problem with that is you're taking basically a dead tissue and you're putting it in there and hoping that the person's body grows into it and keeps it strong, because your body could reject that tissue. That tissue can be from somebody who was 100 years old and they weren't very active, so it's not great tissue. So uh, about 10 years ago, we started adding on what's called an internal brace. Okay, we're still talking about the let me go back to this. So other things to do if you're not exactly sure what you're dealing with, you make sure you have neutral alignment. Neutral alignments mean that the foot is sitting straight. If they have a big curvature of their foot or something that leads them to keep spraining their ankle, maybe I would address that at the same surgery. I would get a MRI if I'm not sure if there's something else going on, so there's a perineal tendon injury or a cartilage injury, and then consider putting the camera in the ankle if I'm worried about any cartilage injuries. So these are all things for pre-surgical. Now, this is all assuming that we've already tried conservative management, anti-inflammatories, put in a brace, go to physical therapy, give it a couple weeks, give it time. Okay. Um, I'm kind of jumping to the treatment surgical aspect of it because to me it's more interesting. So the internal brace, basically, what we do is put two anchors in, one over the fibular side of the ATFL and the other on the talar side. And after you do your repair, you put these anchors in, and it's a flat piece of suture that is very strong. So with a bone anchor. So what you've done now is you've done the regular repair, and on top of it, you've put a repair that is instantaneously strong, very strong. And so that's how we line it up. You put a pin in, so it's not in any joint. As you can see here, this pin is not in the subtalar joint. It's not in the ankle joint. So let me give you some positioning. This is the tibia up here. This is the talus. This is the heel calcaneus back here, and the front of the foot's over here. This is a side view. From the front, you're looking from the front on an x-ray. Here's the fibula here. Here's the talus. Here's the tibia here. So you get this pin to sit in the middle of the talus. You then drill a tunnel around this, and then you put it's a dissolvable plastic peg, which dissolves over years. It has suture coming out the back. And we take that suture, and after we do our repair, we then do another anchor in the fibula. So what this does is immediately you have a strong support so that people can start walking early. So initially when you would do this repair, I couldn't let people walk for 6 weeks, 8 weeks, because you're waiting for that repair to heal, to scar down. But when you wait 6 to 8 weeks, people's muscles atrophy, their joints get stiff, their proprioception for sensing the position of the joints and everything is thrown off and has to take a lot longer to rehab, so a lot longer in therapy. So by letting people walk and get active earlier, especially athletes or rugby players, you have much less recovery time. You can get going faster. The addition of knotless fiber tack. So remember I told you we're doing those two big anchors to go on top of the repair. The initial way you would do the repairs, you would make drill holes or put anchors in the bone to pull the initial ligament, the torn ligament back to the bone. A knotless means they developed a way to basically put a knot of suture underneath the bone. And when you push it in, it balls up on itself, and there is no plastic anchor, no metal, no anything. It gets itself stuck in the bone once you push it in the bone. It has sutures coming off the back. And how is it knotless? It's a mechanism they created where you pass the suture through, and when you pull it, it cinches down into that suture that's down in the bone, and there's no knot to tie. And by not having a knot to tie, people used to feel on the outside of their ankle these knots of suture, and it has to be kind of heavy suture. So they'd feel these knots and it would bother them, would irritate them, and they could feel it. And so, because there's not much skin on the side of the ankle right there. If you touch down on the side of your fibula, you can pretty much feel the bone. There might be a couple millimeters of in between fat and skin. So with knotless, there is no knot to tie. It cinches itself down. So I put in 2 knotless anchors, and I do an internal brace, which is that flat suture on top of it. I don't know if you guys are squeamish, but there's some surgical pictures. Um, that's just showing an anchor going in. Let me get a better one. So that's kind of a schematic picture. You can see the 2 plastic pegs, the flat suture, and then above and below it, you can see those 2 anchors. And there's no plastic peg. That's actually a piece of suture, and it cinches down, and there's no knot. So basically, it's becoming the standard in repairs. It used to be, oh well, we'll only do this internal brace repair if it's a really bad injury. The problem is if you do a repair and then 3 months later somebody tears it again, or you wish that you would have just done the real one, the strong one. And so now I do it on everyone. There's nobody that gets, everybody gets the internal brace, which is the flat suture. Because what happens is in the beginning it lets you rehab faster, but then down the road, if you're playing sports or your foot turns, now that internal brace is a backup to your own repair. So now you have a backup ligament. And now we see this, that people put these internal braces on top of an ACL reconstruction of the knee. They do it on most UCLs for pitchers in baseball now. They add on this internal brace, same thing. It makes it much stronger. Um, Especially people with ligamentous laxity, they have the tendency to tear things again. So those people, it really benefits to have something strong in there. Overweight, obese people, only because they put much more torque and turning and twisting. And of course, impact sports because of the risk of re-rupturing. Let's see. I think I have a video. If you want to watch the video, this is kind of, I think, a quick video of just how it's done.
In this animation,
that's
we will
loud.
show a Brostrom repair with internal brace ligament augmentation. Ankle sprains are very common injuries, and some require surgical repair. The Brostrom repair is the most common technique used to repair the torn ankle ligament. Your surgeon makes an incision on the outside of the ankle over the torn ligament. Using special instruments, a suture anchor is placed into the bone. Next, a second suture anchor is placed. Then an anchor with high-strength suture is placed into the bone below the torn ligament. This high-strength suture will be used as the internal brace ligament augmentation. Next, the sutures are placed through the torn ligament and tied to repair the tear. Then an additional hole is created in the bone, and an anchor loaded with the high-strength suture is inserted. Lastly, your surgeon tensions the high-strength suture and secures the anchor in place. This completes the Brostrom repair with internal brace ligament augmentation.
Okay. Any questions about that? How do I go to the next slide? Hmm.
You could
Vic, how do
page
I?
just arrow down or go to the enter, sir.
It won't let me go down because I'm in this video. Hold on. I'm stuck in their website.
All right.
uh,
Touch on the outside of the screen with your arrow. Yeah, not on your screen, but yeah, there it goes. Here it comes.
Here we go. So after surgery, everybody goes into a boot or splint, staying off of it for 2 weeks. Some docs do let people walk right away, but I usually keep people off of it that first 2 weeks just for swelling. So, because I want that incision to heal, even though it's small, when you put weight on it and you're standing up and you're up around, all that extra fluid goes down your leg. You had a surgery. And so you get some swelling. I don't want to have a wound problem. So I usually wait that first 2 weeks where I tell people to take it easy. But after 2 weeks and we get the stitches out, I let people start walking right away in the boot, start physical therapy, get walking, basically return to sport as fast as they're able to. So fastest, 6 weeks, people are back running, doing everything. Typically back sports 10 weeks. Okay, if people have a lot of health problems. Let's say we're talking about somebody who's elderly and diabetic with a lot of health problems. They're not going to be back running around, but they'll still go back there. But it might take them 2 or 3 months. But for athletes, usually 6 to 10 weeks, they're back running and playing sports. I think that's it, guys. Any questions for me?
Um, Thank you for that excellent presentation. Are there any questions, or Dr. Lopez, do you have anything you'd like to add?
Any of the group have any questions for Dr. Bagwe? Um,
Good evening, Dr.
uh,
Bagwe.
Hi there.
Yes. How are you? Yes. My name is Ashley
Good.
Godraj. Thank you so much for that really detailed presentation, especially with the anatomy and the video showing how the procedure works. Regarding, I guess the anchor, is this a permanent suture that's within the foot, or does it eventually dissolve and then the tendon, I guess, goes back to its original strength? Is this there permanently?
So the suture stays there, it does not dissolve. Okay. But it's the nice thing is if you need to do an MRI or another test, it doesn't mess with the imaging. So when you used to have metal anchors, you couldn't see um, because the metal makes an artifact on an MRI. So let's say you have an ankle injury when you're 15 years old in a surgery. And when you're 40, if you need an MRI, you couldn't see anything because there was a metal anchor. And then the dissolvable ones were nice, but the problem is you had a knot sticking out on the outside. That's the plastic. And then if you use a piece of plastic, the other worry is sometimes people's body, where your bone touches the plastic, sometimes people get a reaction to that plastic, a little allergic reaction, and it could dissolve away or it could get inflamed. So it's nice to have something such as suture, which I've never seen anybody have a reaction to non-dissolvable suture. So no, it's permanent and it stays there. What was the other part of your question?
I believe that was
Oh, the
it, but I
tendon.
guess, yeah, yeah, I guess afterwards, does it help does it being there help increase like the strength of the tendon there?
So the tendon, I know it gets a little confusing because mostly this repair is for a ligament repair. For tendons, the tendon that's nearby would be the peroneal tendon. When I repair peroneal tendons, I use a non-dissolvable suture because the peroneal tendons don't have a great blood supply. So you need something that's pretty strong. So I use a non-dissolvable suture to repair a peroneal tendon. Um, when you sew the native ligament back down to the bone, no, it scars down and it gets strong. And your body does have the ability to kind of basically revascularize and go into injured tissue and kind of make it healthy again. But your body does not have a good way of taking something that's stretched out and making it tight again. So that's where I tell people. I had somebody come in the office the other day with a bad ankle sprain. And when they took the x-ray, just by taking the x-ray with their foot dangling, their foot was sitting, hanging out of socket a little bit like that. And so I know they have to be fixed because your body cannot take something that's torn and spread open and pull it back together. It can mend something that's already in the right place and tighten it. It can't take things that are apart and pull them back together. So so that's where you have to go do an actual repair and sew things back together.
Thank you so much.
You're welcome.
Good evening again. I think that was an amazing presentation. I had also a question. In the beginning, you had said that you have worked 15 years in trauma. How do you think that working with trauma shaped your view in medicine as you continue your path?
Trauma. So most orthopedic surgeons, when you start working or you join any medical practice, you have to be on staff at a hospital. But in training, you do a lot of trauma surgery. That's what you're doing, not all the time, but a good portion, because you need to it kind of serves a purpose of helping out these hospitals by being able to work a lot and taking care of all the injured people. And it's good education for the head surgeons, and then the chief residents, and the chief residents teach the junior residents help teach the students. So everybody goes down the line and teaches more. So you already do a lot of trauma. So that first 15 years of trauma is actually very similar to what I did in residency, which is what I did when I first started doing surgery. So it's not that it shapes it, it's just that it's very time consuming. So you might go, depending on where you're working or how your setup is, I might go to work on take a call for the weekend and leave Friday night and not come home till Sunday evening because there's trauma coming in all night, or just go home to grab a bite of food and a change of clothes. And so it's just very time consuming. So, and it can be very taxing. So, and then sometimes you have on call in the middle of the week and you get called at 2 a.m. and you're doing emergency surgery till 4 a.m. and then you have to see patients starting at 8 a.m. So you have to be physically and mentally just used to that. Now, is that difficult? Yes. And at times you have to make adjustments. And most surgeons, as time goes by, have the younger doctors in the group or other doctors. You can pay other doctors to take call for you. if you have the ability to have other people do that late night and weekend stuff so that you don't have to anymore. And so I don't take call anymore. I don't do that stuff after 15 years, but it is interesting because you take care of everything and you meet all sorts of kinds of people. You meet gunshots, car accidents, people playing sports, they get hurt in games and they take the ambulance there. People in the hospital who work here fall and get hurt. I mean, you see everybody. So you take care of everybody who comes in.
Thank you. That answers my question.
Sure.
Hey, Dr. Bagwe. My name is William McIntyre, like I said before, and thank you for your presentation. Really like it a lot. And my question is, as someone who wants to go into like sports medicine or orthopedics, what's one piece of advice you'll give to somebody right now in our shoes, if that makes sense?
I don't think it's ever too early to start making contacts to find out how you can shadow in an office, meet orthopedic surgeons. And then even if you're in college, start figuring out where the research is being done nearby. So it looks like, not looks like, but so even in your spare time, you're doing something. It can even be biomechanical. It can be literally forces and vectors and machinery equipment, because a lot of orthopedics is understanding measurements, torque, forces, chemicals. I mean, we kind of deal with everything in orthopedics. So you need to kind of get involved in meeting people, getting the references. I have people's friends' kids shadow me in the office and ask me for letters of recommendation, and they come watch surgery. They come to the office. I did research when I was a student at WashU, and that led to some publications, which helped my interviews when I would talk about the research I did. So you kind of have to dive in on all these different levels, on reaching out to getting to know people, shadow in the office, do research, and of course, be able to have your grades and scores in the right category to be able to apply.
Okay, thank you.
Sure.
Hello, Dr. Bagwe. Thank you so much for that presentation. I thought it was really in depth, and as Asha said, starting with the anatomy was really useful for us as the audience. I had a question regarding the decision between the conservative treatment and going ahead with surgery. Is there sort of like one specific criteria that can go into that, or is it more of like a case by case basis? And on top of that, is age a factor in that as well? Because I know you mentioned that people of different ages experience the different injuries, but they also go through rehab at different rates as well.
Sure. So yeah, age and activity level make a complete difference. So for instance, if I have an elderly person who has a bad heart and they're high risk for surgery, and they have a loose ankle, but as long as they wear their ankle brace, they're fine. Well, they're just wearing their ankle brace. There's no surgery. They just need to wear the ankle brace all the time. Okay. Young people who are very active have a much lower threshold. If you're 16-year-old and your ankle's already unstable, and when I mean unstable, we've tried therapy, we've tried rehabbing, and it keeps swelling, it keeps staying painful. Therapy's not improving it. Then that's the decision for surgery. Is there a strict guideline? No, I think once you've got the diagnosis of an unstable ankle and it's affecting your life, and it's not something that you can just avoid. So for instance, let's say your ankle only bothers you when you're running at a full sprint. Then that person would have to decide, do they want to be able to run a full sprint? If they tell you, I'm never going to run, I don't need to run a sprint, so it doesn't bother me, then maybe we wouldn't do the surgery. But if it's a young person and they want to go into sports or have something, be able to do a lot of activities outside, then that might be the deciding factor. So yeah, it's case by case. But usually it's hard to explain. When you've done it long enough, you can tell by the person and their activity level when it's the right time to make the decision to do surgery. And I usually don't tell people, I tell people, I think now's the right time, or I tell them, you let me know when you're miserable, and then we'll go ahead and fix this. And people usually realize they can't do the things in life they want to do. And they say, okay, let's do it. I know what needs to be done. The doc told me what it is. I thought about it. I think I'm ready for it.
Thank you very much.
Sure.
I'll ask a question. With the NBA literature that's out stating that ankle braces are supportive and assist in ankle rotations and further ankle sprains, do you subscribe to that? Where you think that maybe an athlete could benefit from an ankle brace prior to any intervention? Or do you think maybe, obviously you said you have to do it by case, and I agree, I guess maybe you could expand a little bit on that and your
Sure.
experience with that.
Yes, that's a great question, Vic. So uh, for ankle braces, when people are just if people are recovering from a sprain and they want to use an ankle brace in the process of getting back to activity and to feel good, I think that's fine. But then I always tell them you can't keep wearing this. You need to start slowly get rid of this brace. Otherwise, your ligaments are going to be weak, your muscles will be weak, your tendons that normally fire right away to protect you from spraining your ankle, they're going to be on low alert because they're depending on that ankle brace now. So, and that population, while they're recovering from an injury, I like an ankle brace. Okay. The athlete who's just returning to sport, usually I tell them, okay, in the beginning, wear it all the time. Then maybe just wear it in games, stop wearing it in practice, and then stop wearing it in games. Um, and let's say they're at the end of college and they're about to finish their college career. Well, you know what? If it's their last season, maybe they just wear it all the time because they don't want to have a bad ankle sprain and they don't have a long future where it's going to make a difference. They're not going to keep playing after that next year. So then I would say it doesn't matter. If you really want to avoid an ankle injury, then you just wear it all the time. But long term, I agree. I would not recommend wearing an ankle brace all the time or getting dependent on it. I think it does weaken them and it causes the proprioception and the balance and the reaction time for the tendons for balance. I think they'll all get weaker.
Well, thank you. Yeah, I agree with you on that. So the second question I'll have for you, do you think an initial experience with a subluxation is a reason for evaluation for surgical intervention? And this is, I guess, come across a couple of times where players have had a history of subluxation, maybe a first incident, maybe even a second, but they're really not super unstable. What do you suggest in that arena?
Well, so when you say subluxation, I guess that can mean a lot of things. So a lot of times people feel like something's subluxating and it's not their ankle, it's their peroneal tendon subluxating out of socket. Or they have a small peroneal tendon tear and they feel something popping and it's actually one tendon popping in and out of the other. It's usually not the ankle joint. If it's their ankle joint and it's subluxating, that means that they're depending on their tendons and their muscles to hold their ankle in socket, and the ligament's really not doing its job. If they're just walking around and once in a while their ankle subluxates out, they're they're basically ready to have a bad ankle sprain. And usually those people, if they are relaxed and you do a stress view of X-ray and you tell them to relax and you go in there I go in there into X-ray and I have them put their ankle out and I grab their heel and I pull on. It's called a stress view. And if it opens right up and I can pull on that ankle and it opens right up, it's loose and it's not going to tighten itself up. They might be lucky enough that their muscles are keeping them from buckling, but it's only a matter of time before they have a bad sprain or dislocate. So to me, if they have a documented, if you can subluxate them or they see something's popped out of place, they need an MRI because you also could have a little cartilage injury inside the ankle and that pops in and out of place and that makes them feel like their ankle is out of place. Okay, so if they say they have a subluxation and they're an athlete, I'd probably get an MRI unless it was just a one-time thing and it never happened again.
Okay. Thank you. It's very common. You can just imagine with the amount of running and juking in the sport. These athletes come in and I had a subluxation. I'm like, did you have it evaluated? It's like you need to do further imagery. We need to know where you're at with it, what's actually torn, if there is something damaged. So I appreciate your insight on that. I just wanted to hear what you thought about the ankle braces and also the histories, when the athletes come in.
I have a simple test when people say they're ready for sport. I tell them when they can run at a full sprint and it doesn't bother them and they're not limping, that they're at least ready to go back and try playing sport. There's so many things in the mechanics of a full sprint that have to work correctly. So that's when it's at least time to go try practice. They always say, when can my son play baseball? When he can run full speed and he's not limping or it doesn't have something wrong with his gait, he's ready to go back to try to play sports. That's my rule of thumb.
Thank you so much.
Sure, buddy. Thanks for having me, guys.
If there are no questions, that will conclude week 9 of the Rugby and Research Injury Prevention Group Summer Lecture Series. We'd like to give a big thanks to Dr. Bagwe for joining us today and everyone in the audience in attendance. Thank you all for attending.